And next is N2B. In this cases, multiple same side lymph node is been affected, in which uh, the size of the lymph nodes will be up to 3 to 6 centimeter, but not more than 6 centimeter. But N2C means metastasis in the bilateral or contralateral lymph nodes. That is not in the same side, other side is also affected, but the size of the lymph node will be 3 to 6 centimeter in dimension. N3 means metastasis in lymph node, but the size will be more than 6 centimeter in dimension. Distant metastasis M. M0 means no metastasis. M1 means distant metastasis. These are the stages, readable points. Coming to the management, goals of management are to cure the disease, preservation of safe and effective swallowing, preservation of useful voice, avoidance of permanent tracheostomy. Sometimes we have to go for permanent tracheostomy by removing the complete larynx. So treatment options include surgery, radiation, as well as chemo. Prognosis mainly depend upon the stage of the tumor, the patient's gender as well as age, and the pathological feature of the tumor. Complete dental examination should be done before the procedure. If any dental problem is there, it should be treated before the surgery as well as radiotherapy, otherwise risk for infection. So early stage tumors and lesions without lymph node involvement, radiation therapy or surgery may be effective. Chemo radiation therapy provide high rates of laryngeal preservation. Surgical management goals is to minimize effects of surgery on speech, swallowing, as well as breathing, and to maximize the cure of cancer. These are the two goals. So patient with more extensive tumors, tumor T3 and T4, a combined approach may be needed. That is a adjuvant as well as neoadjuvant radiation therapy along with surgical resection. Chemotherapy can be done with the help of cisplatin and 5-fluorouracil along with radiotherapy. So common surgeries are hemilaryngectomy or vertical partial laryngectomy. Hemi means half. In this half of the larynx is being removed. This procedure is well tolerated, but the patient is not allowed to swallow 7 to 10 days postoperatively. So removal of more than half of the if hemilaryngectomy means half of the larynx is being removed, but if you are removing more than half of the larynx or a portion of second vocal cord, half of the larynx is been removing means one vocal cord we will remove. So other than we have two vocal cords, the second vocal cords a portion is also removed in surgery. That type of surgery is termed as subtotal laryngectomy. That means removal of more than half of the larynx or a portion of second vocal cord is called as subtotal laryngectomy. To do this procedure, we will open the larynx through the thyroid cartilage and we will remove the diseased false cord and one side thyroid cartilage. The voice result is Hoya's voice. The patient will be having Hoya's voice. Swallowing ability, initially the patient needs swallowing therapy to learn how to swallow without aspirating. Most common side effects of these surgeries over larynx is aspiration. Supraglottic laryngectomy. Here main side effect is aspiration because the area in which the sensory receptors are present to close the larynx is supraglottic area as well as glottic area. So that area is epiglottic area. That area has been removed. So when cancer invades the supraglottis, a supraglottic laryngectomy is being done. Here the true vocal cords are preserved. Vocal cords are not removing. The patient needs special swallowing training postoperatively. So when aspiration is suspected, what we have to do is give the patient methylene blue dye or grape juice or food with coloring added, and we have to check the tracheal suctioning. Of course, the patient may be undergone tracheostomy, temporary tracheostomy. Through that, we can suction and check the tracheal secretion. If there is presence of dye and grape juice and all, we can think that we can rule out the patient is aspirating. So to do the surgery, we are doing horizontal incision which passes above the true cords, leaving the true cords intact. We are not removing true chords. So the voice result is normal. So we will remove the epiglottis as well as diseased tissue in this. But here also swallowing therapy is important. We have to teach the swallowing therapy initially, immediately after the procedure. Sometimes we will teach the patient before the surgery itself. We will explain everything to the patient, and before only we will start the rehabilitation. After a partial laryngectomy or a temporary, after a partial laryngectomy, we will have the patient will be having a temporary tracheostomy. It is removed when the edema is in the surrounding tissues are subside. Patient is not allowed to use the voice for about 3 days after the surgery in the case of partial laryngectomy. Vocal cord stripping. So in some cases we will do vocal cord stripping. That means we are removing the mucosa of the edge of the vocal cords using operating microscope when the vocal cords are being affected. So stripping should be done when there is dysplasia, that means abnormal growth. Hyperkeratosis means thickening of the stratum corneum due to the abnormal quantity of the keratin. Stratum corneum is the outermost layer of the epidermis. So find out which all are the layers of epidermis and message me. So here the stratum corneum is got thickened due to abnormal quantity of keratin. So we will do vocal cord stripping. Sometimes this surgery will be done due to leukoplakia. Cordectomy, that is complete excision of the vocal cord via transoral laser with the help of laser treatment. A laser probe is inserted through orally itself. Otherwise, laser surgeries are having several advantages. Treatment and recovery are shorter. Few side effects only. Cost is also less. Microelectrodes we are using to resect the cancer. Carbon dioxide laser also can be used for the treatment for many laryngeal tumors. Carbon dioxide laser. Last one is total laryngectomy. Here, complete larynx is being removed. So it includes removal of the epiglottis, thyroid cartilage, hyoid bone, cricoid cartilage, and 3 or 4 rings of trachea. That is also being removed. The pharyngeal opening to the trachea will close, and the rest of the trachea will be brought back to the neck, and we'll suture it to make a permanent tracheostomy. And through that, for the lifetime, the patient will be taking breath through that permanent tracheostomy only. So here you can see the image. The tracheal part, the laryngeal part is being resected, and the opening of the pharynx is being closed here, and the rest of the trachea brought back to the neck, and we made a permanent tracheostomy. Here, what is the difference? The patient is not able to talk because the larynx is removed, and patient is not able to smell also because patient is not able to breathe inside through the nose. Nose is not useful then. കാരണം ഇവിടെ ക്ലോസ് ആയി കഴിഞ്ഞു. ബ്രീത്ത് എടുക്കുന്നത് ട്രക്കിയയിൽ കൂടെ, മീൻസ് ട്രക്കിയോസ്റ്റമിയിൽ കൂടെയാണ്. അതുകൊണ്ട് നോസിൻ്റെ യൂസ് അവിടെ തീർന്നു. സോ സ്മെല്ലൊന്നും പേഷ്യൻറ്റിന് തിരിച്ചറിയാൻ പറ്റത്തില്ല. And in early phases, the patient will be having drooling of fluid from the nose because patient is not able to sniff in and sniff out through the nose. So person has no voice because he is not having larynx. Patient loses the sense of smell because breathing through the nose is impossible. Initially, the person will be having running nose because sniffing in and out is not possible.